Welcome. I hope you're having a wonderful day. We're going to be talking about benzodiazepines. So they are among the most widely prescribed class of medicines. They are used in the treatment of a wide variety of conditions from anxiety to seizures, not least because of their mechanism of action. Today, we review the essential and relevant facts that underpin benzodiazepines pharmacology. Before we review the mechanisms that underpin benzodiazepines pharmacology, let's first review the many indications that they are used to treat. First-line treatment of seizures and status epilepticus. Short-term treatment of both anxiety and insomnia. First-line treatment of alcohol withdrawal reactions. And then sedatives for interventional surgeries. They are also used for spastic and involuntary movement disorders. So, benzodiazepines are compounds whose chemical structure is a fusion between a benzene ring and a diazepine ring. Through this fundamental structure, they exert their anxiolytic, anticonvulsant, sedative, hypnotic, and muscle relaxant properties at their target receptor. Most of the benzodiazepines can be identified through their suffix, PAM or LAM. The exceptions to this rule contain AZE within their drug names. Examples of benzodiazepines include these listed on the slide. There are many more than the ones I've listed here. I tried to pick the most common. 4 of them, alprazolam, which is Xanax, clonazepam, which is Klonopin, diazepam, which is Valium, and lorazepam, which is Ativan, are listed among the top 100 most commonly prescribed medications. The mechanism of action of benzodiazepines is simple. Their target is the GABA A receptor, and it's a chloride channel that opens in response to the binding of GABA, an inhibitor neurotransmitter, to the receptor. GABA is the chief inhibitory neurotransmitter of the central nervous system. Benzodiazepines do not alter the synthesis, release, or metabolism of GABA, but rather potentiate its inhibitory actions by augmenting receptor binding. This binding increases the flow of chloride ions through the GABA ion channel, causing postsynaptic hyperpolarization and a decreased ability to initiate an action potential. Once the channel opens, chloride floods into the cell, meaning the cell's less receptive to the effects of depolarization. That's where the benzodiazepines come in. Benzodiazepines encourage the binding of GABA to the GABA A receptor, enhancing its inhibitory effects throughout the brain. With less depolarization, action potentials begin to dry up. An inhibitory depressant effect takes hold. It is this depressant effect that manifests in the many therapeutic roles that benzodiazepines offer. In real terms, less depolarization means reduced anxiety, increased sedation, increased sleepiness, and anticonvulsive effects. Because the GABA receptor is activated by multiple drugs that are CNS depressants, the combination with benzodiazepines is additive. Neurons in the brain become accustomed to the effect of benzodiazepines, leading to dependence. As a result, when patients need to be withdrawn from the medicines, they should be withdrawn over a prolonged and defined period. This reduces the incidence of withdrawal effects. The symptoms or signs and symptoms of benzodiazepine withdrawal can include tremors, anxiety, perceptual disturbances, and dysphoria. Serious withdrawal effects may include delirium, seizures, and autonomic hyperactivity. Not all benzodiazepines have the same activity. Unique properties of individual benzodiazepines have clinical significance. These pharmacological differences among the benzodiazepines include the rapidity of onset, which is called the distributional half-life. Generally, the onset of action is relatively immediate, with responses within minutes to hours. Another difference among the benzodiazepines is the persistence of active drug and/or metabolite in the body, which is the elimination half-life. They are divided into short-acting, intermediate-acting, and long-acting. The divisions listed here may vary from some of the other sources, as time frames for each source varied. I tried to pick what was average. Short and intermediate acting drugs are generally more suitable for treating insomnia. Long-acting drugs are preferable for conditions such as anxiety. So consider an agent with a medium or a long half-life. Clonazepam, lorazepam, and diazepam are often used. Shorter acting agents pose higher risk of withdrawal, rebound, and dependence because the body has less time to adapt by either upregulating or downregulating receptors and transporters in response to the sudden disappearance of the effect produced by the benzodiazepine. So I have this little mnemonic here with the short-acting ATM drugs, the intermediate-acting TLC drugs, and the long-acting CDC drugs. And diazepam's in the long-acting one, and it's the most well-known. Alprazolam concentration peak when taken orally is between 1 to 2 hours, while lorazepam's peak is in 2 hours. Thus, alprazolam is the drug of choice for rapid euphoria in abuse situations. Long-acting compounds have a greater risk of accumulating in the elderly, especially in patients with reduced liver function. But again, long-acting compounds are associated with reduced rebound effects and reduced withdrawal effects. All benzodiazepine drugs have the potential for abuse, some more so than others. When determining a benzodiazepine's strength, there are two things to consider: the drug's potency and its half-life. A half-life measures how long a drug takes to break down and exit the body. A low-potency benzodiazepine with a long half-life is weaker than high-potency benzodiazepines with a short half-life. Drugs with a shorter half-life, while more short-acting, are often felt more intensely. Drugs with a short half-life also create their effect more rapidly. These characteristics make these substances more attractive to recreational drug abusers. So the benzodiazepine drug abusers often prefer short-acting, high-potency benzos, such as lorazepam or alprazolam, due to their fairly rapid and intense high. Of the two, alprazolam is considered the most abused. So let's look at the comparison of lorazepam and alprazolam. So lorazepam may cause drowsiness in about 15% of people taking the drug for anxiety. Xanax, however, which is alprazolam, may cause drowsiness in 41% of people taking it for anxiety, and nearly 80% of people taking it for panic disorder. The bottom line is that Xanax is more sedating. Ativan can impair learning and coordination and cause amnesia for longer periods than Xanax. In general, Ativan causes fewer withdrawal symptoms and has less potential for misuse than Xanax. This is likely because Ativan has a more prolonged effect and slower elimination rate than Xanax. In general, Ativan causes fewer withdrawal symptoms and has less potential for misuse than Xanax. This is likely because Ativan has a more prolonged effect and slower elimination rate than Xanax. It is more likely that missed doses or abruptly stopping Xanax can cause rapid withdrawal effects, including anxiety, insomnia, and panic attacks. Xanax may also be involved in more overdoses than Ativan. The bottom line with all of this information is that I avoid prescribing alprazolam, which is Xanax. All benzodiazepines are metabolized by the liver and excreted by the kidney. Some are just metabolized by different pathways that are less dependent on global liver function. Most benzodiazepines are oxidatively metabolized by the cytochrome P450 enzymes, which is the phase 1 of metabolism, conjugated with glucuronide, which in phase 2, and excreted almost entirely in the urine. The LOT drugs are those metabolized mostly by conjugation. So these three drugs, the lorazepam, oxazepam, and temazepam, they don't have active metabolites, and the half-life remains relatively the same even in the setting of liver disease. Within the liver, most benzodiazepines are metabolized to a significant extent by CYP2C19 and CYP3A4. Examples of drugs that inhibit CYP3A4 and reduce the metabolism of benzodiazepines, thereby prolonging their effects, include macrolides, diltiazem, HIV protease inhibitors, grapefruit juice, and tricyclic antidepressants. Inducers of CYP3A4, which may enhance metabolism of benzodiazepines, include phenobarbital, fentanyl, carbamazepine, rifampin, and St. John's wort. Oxazepam, I can never say it, the O of a lot, temazepam, and lorazepam are directly conjugated in the liver during phase 2 metabolism to an inactive water-soluble metabolite that's excreted by the kidney. Therefore, these agents are not susceptible to CYP interactions and are less likely to accumulate in patients with CYP inhibition. Side effects. Benzodiazepines are associated with drowsiness, sedation, decreased alertness, psychomotor retardation, lack of concentration, and decreased libido. So psychomotor slowing may be especially profound during the initial administration of a benzodiazepine or with a sudden dosage increase. It may also be noted in patients such as the elderly who have decreased rates of metabolism or greater susceptibility to central nervous system depression. Psychomotor symptoms include drowsiness, poor coordination, ataxia, dysarthria, motor incoordination, diplopia, muscle weakness, vertigo, and mental confusions. Studies of psychomotor effects suggest that benzodiazepines slow reaction time and impair driving skills, increasing the risk of motor vehicle crashes in patients who are taking these agents. A contraindication to the use of benzodiazepines is acute chronic narrow angle glaucoma, as it can dilate the pupil. Benzodiazepines should be used in caution with patients with compromised renal, hepatic, or pulmonary systems. They're eliminated by the kidneys after metabolism by the liver. They may cause hepatic encephalopathy with liver cirrhosis. They also depress respirations, so should be used in caution in pulmonary disease or musculoskeletal diseases that inhibit respiratory musculature. Due to their additive effects with other CNS depressants such as alcohol and opioids, they should be used with caution in patients with a history of substance abuse, as it may cause significant respiratory depression. The elderly appear to be more sensitive to the effects of benzodiazepines, both because of changed pharmacokinetics and pharmacodynamics with aging, and because of altered post-receptor cerebral response. All problems identified with benzodiazepines, such as dependence, withdrawal, and cognitive and psychomotor impairment, are proportionally greater among the elderly, who can least afford these risks. Benzodiazepines are on the Beers list and may contribute to cognitive and psychomotor impairment in elderly patients, contributing to falls and auto accidents. So, some key clinical considerations. When we talk about benzodiazepines, we need to think about that the elderly are more likely to experience side effects, including falls, and so it should be administered with a reduced dose. That withdrawal and rebound effects are less likely to occur with long-acting benzodiazepines compared to short-acting drugs. That benzodiazepines should be avoided in patients with significant respiratory impairment or neuromuscular disease such as myasthenia gravis. That benzodiazepines should be avoided in patients with liver failure due to the risk of hepatic encephalopathy. However, if their use is necessary, drugs such as lorazepam, which relies less on the liver for metabolism, may be used. And you need to think about that side effects of benzodiazepines are increased in the presence of alcohol and opioids. Thank you for your time and attention.